Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope. Today on Healthy Minds.
One of the things that happens with rapid-acting antidepressants, again, at least with ketamine, because they tend to work by mechanisms that are really quite different than the usual antidepressants, that they're often helpful for people who have not responded to the standard antidepressants.
What we refer to as treatment refractory or treatment resistant people who didn't get better from the Prozacs and Zolofts type of medicines.
Because we can get people better so quickly, sometimes within hours of the initial drug infusion, that we might be able to use ketamine in urgent care settings, like emergency rooms, like urgent visit centers.
That's today on Healthy Minds. This program is brought to you in part by the American Psychiatric Association Foundation, the John and Polly Sparks Foundation, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Today we speak about exciting new developments for the treatment of depression. I'm joined by Dr. John Crystal, a leading expert who's been involved in the development of rapid-acting antidepressants, which, instead of taking a few weeks to take effect, work within a few hours. John, thank you for joining us today. I want to talk to you about rapid-acting antidepressants. So, to start with, what are they?
Well, rapid-acting antidepressants are something that are really new in psychiatry, but something I've lived with for about 25 years. When we think about treating depression with medications, we're usually thinking of medications like Prozac or Zoloft. And these are medications that people start on the medication, they take them every day, and the hope is that after several weeks or sometimes a few months that they'll really get back to themselves. With rapid-acting antidepressants, at least as we think about ketamine as a prototype for rapid-acting antidepressants, it's a medication where a certain percentage of the people can expect to get better within 24 hours of the first dose of medication. And these medications are often medications that you don't take every day, but where you take periodically. One of the things that happens with rapid-acting antidepressants, again, at least with ketamine, is that because they tend to work by mechanisms that are really quite different than the usual antidepressants, that they're often helpful for people who have not responded to the standard antidepressants.
What we refer to as treatment refractory or treatment resistant people who didn't get better from the Prozacs and Zolofts type of medicines.
Yes, and one of the things that we've learned about treatment-resistant symptoms of depression is that they can often be invisible to people. So, as one might expect, no single medication works for everybody. And so it's really important to take the remaining or residual symptoms that people have seriously, because they constitute a real burden on the lives of people. And so when we come up with a new intervention, particularly one that can work so rapidly, it can have a really major impact on the lives of people who have been struggling with depression.
So you mentioned ketamine as a prototype of this. Mm-hmm. Ketamine has been used in anesthesiology. It's been used as a drug of abuse. Talk a little bit more about ketamine.
Ketamine, in some ways, is a very old drug, but it's also, in other ways, it has been a tool that we've been able to use to open new doors in terms of understanding of the brain. So ketamine was developed as an anesthetic drug, and it works as an anesthetic drug because it blocks a particular type of receptor. This is called the NMDA subtype of the receptor for glutamate. Now, what is glutamate? When we think of psychiatry, we're usually talking about transmitters that have names like dopamine, norepinephrine, and serotonin. These transmitters are collectively called the monoamine system of the brain. And these monoamine chemical messengers emerge from primitive parts of the brain, and they tune the activity of the higher brain centers. The higher brain centers are regions like the limbic system or the cerebral cortex. These are the areas that are controlling our thoughts and our emotions. So for a long time, psychiatry focused on the monoamine systems and ignored the signaling of the cortex and the limbic system. Since the 1950s, the medications that we have used to treat depression have targeted the monoamine systems and been involved in tuning the higher brain centers. But what if we approached depression from the perspective of what's going on in the limbic system in the cortex? If we want to target the limbic system in the cortex, then we have to speak the chemical language, the same chemical language that the cortex and limbic system use. We wanted to study ketamine effects in depressed people because we wanted to test what would happen if we manipulated glutamate signaling in the brain. We thought maybe depression doesn't live in the primitive parts of the brain. Maybe it's a property of the higher centers of the brain. And we thought we would learn something about that if we gave even a single dose of ketamine to people who were depressed. When we did that, somewhat to our surprise, we found that within 24 hours of a single dose of ketamine, that some people reported feeling much better. In other words, not just having a reduction in the burden of their sadness or their inability to experience pleasure or the disruption of sleep, but the whole picture. In other words, that they had returned to themselves in a way. We found that shocking, and it took us a long time to really believe what we were seeing. And I think it took the field a much longer time to believe what we had reported.
But there was a basis in terms of the basic neurochemistry of the brain, that this was targeting specific neurochemicals and regions of the brain that could have that effect.
Exactly. We didn't expect to see the rapid response, but when we saw it, it was very compelling to see. And over time, other groups started to study the ketamine effect. The findings turned out to be strikingly consistent. And so after a while, clinical programs started to implement ketamine as a treatment, which also helped us to learn more about it. In the treatment of depression, it is very common to get people better, but it is a very big challenge when they then have a relapse of their depression to know what to do to help them to get better, and just to deal with the impact of a discouraging return of depression symptoms. If we can reduce that, as well as reduce relapse, as well as getting people better more rapidly, then I think that this begins to change what it means to be depressed. Because depression is so bad, and people face so much uncertainty when they struggle with depression, that having a drug that can get you better quickly and help you to stay better could have an impact.
One of the symptoms of depression that's of great concern is suicidality, thoughts of hurting oneself and actually harming oneself. And these rapid-acting antidepressants have an effect on suicidal thoughts as well. I'd like you to speak about that.
Yes, I'm glad you mentioned that, because as doctors, we have a kind of hierarchy of priorities that we have in treating patients. First and foremost, we want to make sure that patients are safe. Then we want to make sure that they can function. And lastly, that they can live their life as fully as possible. And because safety is such an important concern, the idea that we could have a drug that for the first time in depression could have a specific effect on suicidality could be very important. In the studies conducted at the National Institute of Mental Health, improvement in the suicide item of the depression scale stood out very early in their studies. And that finding has since been replicated time and time again. This is really important as we think about the different settings where esketamine or ketamine might be applied. So for example, one of the thoughts that we have had about it is that because we can get people better so quickly, sometimes within hours of the initial drug infusion, that we might be able to use ketamine in urgent care settings, like emergency rooms, like urgent visit centers, or maybe even in home settings, going to people's homes and treating them there, where we could intervene in their acute state of depression and prevent their need for hospitalization.
So instead, if somebody is depressed and suicidal, and they come to an emergency room with the traditional treatments, they may need to be admitted to the hospital and stay there for a period of time until the depression begins to lift and the suicidal risk begins to lift. With the rapid-acting medications, they could be treated, and a few hours later, the suicide risk may decrease, so they could go home and continue treatment safely on an outpatient basis.
That's really what we're hoping for. You can imagine how many families have been disrupted when a parent has to come in for a stay in the hospital. How many people have lost their jobs because they had to leave work in order to come into the hospital and take time out to recover. And you can go on and think about the ripple effects of severe disabling depression for individuals, for families, for society. If we could get people better and shorten or even prevent hospitalization, that would be a wonderful outcome of this rapid-acting antidepressant research.
In many ways, it's a game changer for the field of psychiatry and for patients who have depression and are at suicide risk.
Well, as someone who's worked in this area for a long time, it's certainly what we always hoped for. And we really do hope that it'll turn out to be helpful in these areas.
I'd like you to tell us about some of the side effects of these medicines.
Sure. Well, ketamine is very different than almost any drug that most people will have been exposed to in their lives, unless they've had prior exposure to certain anesthetic medications for surgery. Ketamine is a drug that at very low doses has effects that are similar to about a glass of wine. As you increase the dose of ketamine, people feel, you might say, more and more intoxicated. But as you get into the range where ketamine starts to be able to evoke its antidepressant effects, then some people will have distortions in their perception of their body or their self or their environment. They may feel that the walls are breathing or their body is changing shape or other kinds of distortions, sensory distortions like that. And we call that collection of symptoms dissociation symptoms. And those are very common in the dose range where ketamine produces its effects. Those effects are very short-lasting. When administered in the typical way that we do it, which is a 40-minute intravenous infusion of the regular ketamine, or in the middle of the puffs of the intranasal S-ketamine, those effects come on sort of in the middle. They last for about a half hour or so, and they tend to go away rapidly because ketamine is a very short-acting medication. But they're very safe, they go away. We have not had people who had those symptoms persist for long periods.
So it only lasts during that period of time.
Yes. I think the other main risk of ketamine is its abuse liability. And there are parts of the world, like in China, where ketamine is a very commonly abused drug. And we don't want that to happen, because when people become abusers of ketamine, rather than getting antidepressant benefit from ketamine, they can even be put at risk for depression, because people who are abusers use way too much ketamine. They use it much more frequently than we would use it therapeutically. In order to explain that, let me tell you a little bit about how we tend to use ketamine in treatment. Generally, people start out for 3 or 4 weeks getting ketamine twice a week. Then they go to ketamine once a week. Most people who are treated with ketamine once a week for several weeks will be able to go to ketamine 1 dose every 2 weeks. And in our clinic, somewhere around 30–40% of patients will be maintained on one dose of ketamine every month, or sometimes even less frequently. And so this is a very little period of drug exposure. Ketamine is a short-acting medication. And if you're getting one dose of medication every 2 weeks, that means most of the time there's no ketamine in your system at all. It's really, ketamine works by evoking a response in the brain. And it's the response in the brain, not the presence of the drug, that's therapeutic.
It almost resets the brain.
Yes.
And that resetting stays in place for a period of time, and then another dose may be needed to again reset.
Yes. When people abuse ketamine, though, instead of taking it once a month, people can find themselves taking it every day. Instead of taking it just once every day, they may take it 5 or 10 times a day. So ketamine abuse is really not at all like the way that we give ketamine for the treatment of depression. And in order to prevent that from happening, we try not to let people take ketamine home to use. Because what happens when people get ketamine to use at home is they tend to use it to stave off depression. But in everybody's life, even when treated on ketamine, you have good days and bad days.
The normal ups and downs of everyday living.
That's right. But if you're recovering from depression, there's always a concern that the bad days are warning you of a return of your depression. And so if someone has ketamine at home, there's a real risk that when you're having a bad day, you're going to turn to ketamine to assure yourself that you'll be okay. And that sets people up to develop a habitual ketamine use of the kind that reduces the effectiveness of ketamine rather than gets the most out of the benefit of ketamine.
So at this point in time, somebody's watching now, and they have depression that hasn't responded to other medications, or their loved one is in that situation. What should they do?
Well, we view ketamine as an intervention, not a treatment. And by that I mean that we always think about ketamine and its role in the overall treatment of the patient, which means we're thinking about the whole patient, the whole situation they're in, and what's best for them at the time. Oftentimes, the thought about ketamine comes up right now for people who have tried multiple drugs and who just aren't getting better. There are now clinics growing, places around the country where people can get access to ketamine. In Connecticut, for example, some of the insurance providers are reimbursing ketamine treatment for treatment-resistant symptoms of depression. I think that the S-ketamine availability will be a bit of a game changer in terms of broadening the availability of ketamine-like treatments. And the reason is that a lot of psychiatrists don't like needles. It's not that they don't like them as an idea, but they don't use them every day in their clinical practices, and they haven't set up their offices to manage patients who need intravenous infusions. That requires more of a clinic setup than most psychiatrists have. Because S-ketamine is an intranasal preparation rather than an intravenous preparation, psychiatrists probably will feel more comfortable enabling the administration of the intranasal form of S-ketamine. And I think that that will probably make these kinds of treatments more available. In other words, people will come to the office situation. The office will be well set up to manage patients who are getting ketamine, and that will broaden the access to these rapid-acting antidepressants.
So people won't get a pill or a nasal spray to take home. They'll take it in that clinical setting where they could be monitored, make sure that they're okay, and then they would go home.
Yes. It's important that people be monitored because there are some other side effects. For example, ketamine can briefly raise your blood pressure, and although we hardly ever need to intervene for safety reasons to manage blood pressure, there are some times that we do give medication, pre-medication to keep the blood pressure steady. Also, some people find that the ketamine makes them nauseous, and they may even vomit. And if they do, we can give them medications to prevent the vomiting that makes the ketamine much more tolerable. So like any medicine, it has its effects, it has its side effects, and we can manage those in the clinical office setting much better than people could if they were on their own at home.
Where do you see this going? What's the next steps in terms of the development of new treatments along these lines?
Well, I think that one of the exciting things that has come out of the depression research has been its ability to stimulate more brain research. And colleagues have been probing the neurobiology of how ketamine produces its rapid antidepressant effects. And to me, the findings are really exciting in that we've long known that chronic severe stress, conditions like depression, have a tendency to impoverish the brain of some of the synaptic connections that nerve cells use to communicate with each other. One of the things that Dr. Duman and Dr. Agajanian first found is that within 24 hours of a single dose of ketamine, in regions of the brain involved in the regulation of emotion, these synaptic connections can grow back. And so we're enabling the brain to function more efficiently, more effectively, and it's the brain functioning more effectively that we think accounts for the antidepressant effects. So what we're kind of interested in is what are the different ways that ketamine produces these effects, and perhaps there are ways to target the individual steps in the pathways in the brain through which ketamine works to generate other new treatments for depression. And there are various groups that are exploring a number of different mechanisms to see if they will be antidepressants in their own right.
I want to just ask you about other conditions. So we've been talking about ketamine, S-ketamine for depression.
Right.
But I'd like you to talk about the potential for their use in other conditions, such as obsessive-compulsive disorder, such as depression in the context of bipolar disorder, etc. Say a little bit about that.
Well, I think this is also an important area of research. In psychiatry, we hardly have any specific medications. In other words, our antidepressants are good for anxiety disorders, obsessive-compulsive disorder, depression, and other conditions. Our antipsychotic medications are used for psychosis, but they're also used for mood stabilization, and so on and so on. Why would we think ketamine would only work for major depression? The data do suggest that it works just as well, maybe even a little better, for people who have depression in the context of bipolar disorder, particularly bipolar depression. And ketamine is now being studied for a growing number of conditions, including obsessive-compulsive disorder, borderline personality disorder, and post-traumatic stress disorder, a disorder where we have very few effective or FDA-approved medication treatments. So far, it's early days for all of these other conditions. There are some mixed data about the effectiveness of ketamine for the obsessional part of OCD. It does appear to be helpful for the depression part of obsessive-compulsive disorder. The data in bipolar disorder, I think, is pretty conclusive. And in post-traumatic stress disorder, there's one very encouraging study, and there are a number of follow-along studies, including one that we're conducting now with support from the Department of Veterans Affairs and the Department of Defense. We hope within a few years to have a lot more information about the use of ketamine for these other conditions so that we can use real research data to guide clinical practice. That's the science of psychiatry.
John, I want to thank you so much for the work that you've done to help bring this about. That's helping and will help countless people, and for coming here today to share this with us. Thank you.
Jeff, thank you so much.
Basic research and an understanding of the brain can help scientists develop new treatments for conditions such as depression. Today we heard about the development of rapid-acting antidepressants, which help people who have a depression that may not respond to the traditional treatments. For those people, the message is, with help, there is hope. Do not suffer in silence. With help, there is hope. This program is brought to you in part by the American Psychiatric Association Foundation, the John and Polly Sparks Foundation, and the New York State Office of Mental Health. Remember, with help, there is hope. Until next time, I'm Dr. Jeff Borenstein.